Go ahead and get going. It looks like it's noon here. We do have a few more participants who've registered, so we might have a few more joining us. But I wanted to welcome you to the Mental Health Needs of Refugees webinar. This is Alyssa Clayden will be our speaker today, and I'll introduce her in a second. Okay, so this is sponsored by Iowa SOPI. The webinar is designated for 1 CHES credit today at the CHES level. It is free for Iowa SOPI members or anyone not seeking credit. If you are requesting credit and you're not an Iowa SOPI member, the cost is $10, and you can submit payment if you haven't already at the website listed on the screen. And I'm pleased to introduce you to today, Alyssa Clayden. She has been working in the field of refugee and mental health for 20 years in a variety of roles across 5 continents. Alyssa is a licensed independent social worker, a member of Physicians for Human Rights, and a PhD candidate at the University of Iowa with a research focus in refugee mental health. She's also the executive director of ABCD Therapy and Consultation, an agency that provides transcultural education, research, and technical assistance for agency diversity and equity outcomes, as well as education in increasing provider skills and resiliency to improve health and mental health outcomes. I really think you'll enjoy the topic today. Following the webinar, we will be sending out an evaluation, and we'd ask that you all complete that. It is required if you are seeking CHES credits. So that will be following the webinar. But if you want to go ahead and write in the chat who is on this call today, that will help us a lot. And now I'm going to turn it over to Alyssa to begin our webinar. Thank you.
Thank you so much. I'm glad that everyone's here today. I have some sickness, so I am hopefully going to be easy to understand. If you have any trouble, just speak up. I'm going to share a PowerPoint with you all. So as Tiffany said, my name is Alyssa Clayden, and today, we only have an hour, so I really want to emphasize how brief of an overview this is. I've been doing this work for a really long time, and I find that I continue to not really have any idea what is going on. And so I expect that you'll have questions, or that I might briefly move over a topic that you want to talk more about. So the plan is to have some time after talking through the PowerPoint to be able to answer questions and have more of a conversation, because I know that everybody comes to this with different experiences. So just to make sure that we're all on the same page, I want to make sure that we have this definition of what is a refugee for today's talk. So there are lots of different ways that people are looking for international protection, but in terms of what I will be presenting on today, we'll just be talking about those who have the legal status of being a refugee that are here in the United States. So a refugee means someone has been granted legal status and that they have been granted international protection. There are asylum seekers, and there are many of them. Asylum seekers are asking for that international protection, but they don't have legal status to be called a refugee. So anyone that we're talking about today is someone who is not only in the United States legally, but also has access to certain services and programs that someone who might not have legal status wouldn't have access to. Looking globally at what the refugee picture looks like, the most recent data that we have is from the end of 2018, and it had 70.8 million people displaced worldwide. And out of that 70.8 million, only 25.9 million have been granted refugee status. So there's a large number of displaced people who either don't qualify for refugee status for a variety of reasons or are in process of applying. And then more than half of that 25.9 million who do have refugee status are children, so under the age of 18, which I think is really important to know. And then when you look at refugees globally, the top 7 countries that have refugees, or that are sending refugees worldwide, are Syria, Afghanistan, South Sudan. And those 3 countries alone make up 55% of all refugees across the world. And then Myanmar, Somalia, Sudan, and the Democratic Republic of Congo are the other 4. And all of those together are about 70% of all the refugees worldwide. In Iowa and in the Midwest of the US, we house refugees from all of these countries. So I think that is also very useful to know. The other thing I want to make sure that we talk about before we look at refugees and their mental health needs is this concept of cultural humility. And so just very, very briefly, the way that I practice and the way that I encourage other health practitioners to practice in terms of cultural interaction with refugee communities is this idea of cultural humility. So there are these 3 key tenets that come with cultural humility. So the one is this idea of lifelong learning and critical self-reflection. So really being able to allow for the fact that every single person is this complicated, multidimensional being, and that means that we are ourselves, and that takes ongoing knowledge building and reflection, and so is everyone that we work with, so that it makes it harder for us to generalize and simplify what we see happening in front of us. It requires us to think more about ourselves and others in a much more 3-dimensional, multidimensional context. The second one is this idea, and I think this is particularly important in the health world, this idea of recognizing and then attempting to mitigate the power imbalances that are inherent in patient, clinician, client dynamics. I practice as a narrative therapist. Most often that's the basis of all of my training and my value systems and framework. And as a narrative therapist, one of the key components is this idea of I am not the expert, the client is the expert. And I think that cultural humility asks us to look in that direction as well. This idea that there are these power imbalances in these interactions, and that one of the ways that we in the health field can do a better job of working with people is by being able to provide more power to the client in those dynamics and allow them to be experts on what they're asking for and what they need. And then cultural humility, often this gets left out. So if you've learned about cultural humility, this may be new to you, is this idea of institutional accountability. And again, I think in the health field, this is something that's worth really thinking about and talking about. So it's not just about one person trying to recognize those power imbalances and critically self-reflect, but it's about working within institutions and requiring the institutions within which we work to be accountable to stepping back and reflecting and continuing to grow. And we won't watch it here, but I put a link to a video on YouTube that's phenomenal. It's about a 30-minute documentary, and it's by Tervalon and Murray Garcia, who are the ones who came up with cultural humility at the end of the 90s. And it really, I think, does a good job of explaining what cultural humility is and how we can work it into our conversations and into our work in the health field. Okay, so let's get down to mental health. So refugee mental health needs and experiences in the US. These are really diverse and very different depending on where you go, but there are also some really interesting themes that have happened over the years. So really early research and perspectives in the US started to come from post-World War II. So the early research really looked at people who were being resettled after World War II, Jews and individuals who'd been targeted in camps. They were being resettled, but there wasn't actually an official and structured refugee resettlement program until 1980 in the US. And right before that, right before some of that legislation came through in the 70s, we actually started bringing over Vietnamese and Laotian families, Cambodian families. Those individuals started coming over. As it became a more formalized process, we were able to move from the 80s into a more structured system that we see more of today. But in those early years, what we really saw was people sort of coming over as they were being identified as in need. And there wasn't always a way for them to be really clearly identified as if they needed refugee status or if they needed support in the short term and then could return home. And so there's been, historically, we've had sort of some confusion. What is particularly interesting, I think, is that a lot of the early research was done specifically with Vietnamese populations that moved to the US. And that research has often been applied across the board to all other refugee populations since then. And what we're finding as we start to think more about that is that that doesn't always make sense. So what works for resettled Vietnamese communities or what didn't work doesn't always match what's happening with refugee health and mental health needs now. In the research that we look at, and still some today, there's a push to change it some, but there's been this really consistent focus on refugees in their pre-migration and migration stages. So pre-migration is any time before they had to leave, and assumes that there is this conflict or war that is occurring, or the persecution that makes someone a refugee, eligible for refugee status, excuse me. And that then migration itself, so the act of being forced to flee and then having to physically flee, the loss of family that comes with that, and then being in an intermediary space. So living in refugee camps. For some of our communities that resettle in the US, they've been in refugee camps for multiple generations. There are definitely individuals who get resettled here who don't have a memory of having lived outside of refugee camps. And so that's historically been our focus, this trauma and conflict that has occurred before anyone was even resettled. Excuse me. There are a number of studies that talk about how refugees show this greater level of psychological disturbance over the general US population. And in particular, the studies are looking at diagnoses. And these studies talk about the incidence of PTSD is about 10 times what it would be for the general US population. And depression is about 3 to 5 times. It depends on what study you're looking at. And so there's definitely a lot of research that points at these concerns, these mental health concerns, in terms of diagnoses. Something that I think is very important to think about in terms of mental health in a refugee context is that within that refugee context, mental health is so much more than just a diagnosis. So in the US, we have a tendency to really medicalize trauma. Over the past 20 odd years, the idea of trauma has really taken hold. People have a sense of it, really in any field that you're in, people can talk about it. I hear it talked about, even just like on the street or in shops when people are reading about something or talking about an incident. So it's become very much a part of our vernacular, and it's definitely something where when we think about trauma, we assume that it leads to this medical diagnosis. There's also in the US a really strong sense of what to expect from a trauma survivor. So how should they be acting or behaving or feeling? And when these expectations are not met, there tends to be this idea in the mental health field and in the health field that therefore that individual isn't traumatized or isn't having mental health issues. And this is something that I see a lot. Oftentimes people will be operating day to day very well in refugee communities. And when I come across them, it's often not because they've been referred to me for mental health needs. It's maybe for something else. They're just looking for some information. And we start talking, and I find that there are these pieces that are underneath that no one has identified before. What I think is also really important is that what any of us might assume is trauma is not always what the refugee individual or family or community sees as trauma. So I think a really good example of this is often with children. So I often work with schools or with families, and when a referral is made by a US agency, I will be told that the child is a refugee youth and that they have behavioral issues and that it's obviously related to trauma. So when that young person comes and visits me, I'll have a conversation with them. And the assumption up front is probably around what happened with migration, what did they see? And I may find out that there's some historical trauma there. So it could be the poverty that they were living in. It could be that they, with some of our Syrian families, the children were involved in that physical trek that was very difficult and very complicating in terms of their development. There are all kinds of things that have happened to them. But when I start talking to that child, what they're identifying for me as causing the behaviors has nothing to do with a refugee history. So it might have to do with dad has left home, or a parent in the household has started drinking, or the child feels that they should quit school and get a job. And so they don't understand why they have to go to school. And so they're acting out at school because they feel like they would be better able to serve the family if they were bringing an income. So jumping to an assumption that because someone has a refugee background, that all of their concerns and all of their distress is very specific to that historical trauma can sometimes be very limiting in terms of being able to actually help support what it is that's needed. I want to give an example of the tsunami in 2004. I don't know if you'll all remember it, but there was a major tsunami. It was December 26th, Boxing Day of that year. It was in the Indian Ocean, and there were 14 different countries affected across 2 continents. They estimate around 230,000 people were killed, and many of the locations that were hit were European and American tourist spots. And it was during the Christmas holidays. So there were a lot of Europeans and Americans that were traveling there. And so if you look at European and US media about that, and if you look at that media, there are a whole bunch of articles that were written 10 years after by the same Western media. It talks about how difficult this was and how traumatizing and how awful. And it very much creates a narrative of distress and of trauma. But what's really interesting is in 2004 to about 2006, there were psychologists and psychiatrists who traveled into those countries in an attempt to help with those who had been impacted, and very different reactions were reported by the people who were on the ground. So many of the countries that were impacted have a heavy Buddhist following, and those who were Buddhist consistently described the tsunami as a natural act beyond human control. And when they were dealing with it in terms of defining it, we had American, Canadian, UK individuals who were overseas trying to do trauma work. What they found was that in these Buddhist communities, they were not expressing trauma or trauma survival. They had been able to come to terms with it very quickly and to adapt and to move through it by being able to consider it as a natural act beyond human control. They had something similar happen with some of the Muslim populations that they were talking with. The idea that many people reported was that it was a punishment sent from God. But this wasn't considered a terrible thing. So in many ways, how people described it was that it had been earned, that something had happened or multiple things had happened where they had earned punishment sent from God, but it also provided the opportunity for them to attempt to change and improve what they were doing to try and make it up to God. Again, within these communities, what we would expect to see in terms of being traumatized wasn't there. The communities had pulled together, had had conversations, and had been able to process through the tsunami and the impact of multiple deaths and destroyed villages, and they had moved on through. For those that didn't fall within these Buddhist or Muslim communities, there were also these other communities that built up this collective meaning. And they, whatever that meaning was, they established it, they applied it, and then we didn't see the kind of trauma symptoms that we were expecting. And I think that this is a really important example to think about, because when from a US perspective, when we try to apply what we think is happening and what people are experiencing, we actually end up putting up barriers to supporting the individuals that we're trying to help. And I think that this very clearly illustrates the ways in which we can go in with certain expectations, where we might expect them to act or behave or feel a certain way, and we can be completely off from where that individual is. So when refugees are coming to the US, there are all these ideas about how mental health is impacted by their cultural norms, their beliefs, and their experiences. Something that I think is really important to think about as refugees come. Often refugees are not assessed for mental health needs while they're overseas. So that if they receive refugee status, they have to be, they have to go through a series of orientations and assessments, and mental health is not prioritized in these assessments. However, there are a few who will come through who maybe have a significant diagnosis. So something like schizophrenia will sometimes come through. Sometimes things will be reported, traumatic experiences of sexual assault or torture, but often not. What we see is for individuals coming in, the first 3 to 6 months, there really often are not very clear mental health needs identified. Most of the individuals that I work with have been in the United States for a while. And for recently resettled refugees, we don't tend to see mental health needs arise until 6 to about 18 months post-resettlement. But there are individuals who show no identifiable signs of mental health needs until sometimes many, many years down the road. In Iowa, for example, at the moment, we have a large number of Vietnamese, Sudanese, Bosnian communities who've been in the US for many, many years, decades. And those communities are having kind of ebbs and flows. So in the last year, the Bosnian community has had an increase in individuals seeking out mental health support. And in some ways, this makes a lot of sense because many of those Bosnian families are having their children reach adulthood. So there has been a major shift in their households in terms of what the parents see their role as. And oftentimes you have issues with things like more collectivist cultures would expect their children to be staying in the household longer or providing a certain kind of support for the parents. And in a lot of these communities, the children have been raised almost wholly in the United States. Some have been born here. And so they are operating on a more individualistic kind of cultural training. And so there's a lot of shifting that happens in the communities over time. There also is a lot that comes up in terms of the loss of role in the family. So I tend to work a lot with men who have workplace injuries that don't ever resolve. And they will be from families that from the time of resettlement until the injury, things were going well. They've maybe been here 3 years, 8 years, 12 years. And then there's this injury. And it becomes very complicated for them because the household went from not only surviving, but feeling like they were doing well, that they were thriving, that they were able to fulfill the roles that needed to be done. Nobody was concerned about financial issues. And then one thing happens and they're not able to get the kind of support in terms of government support around a workplace injury, and things start to get very, very messy. Oftentimes workplace injuries lead to additional chronic illnesses. Things like diabetes tend to happen in a similar time frame, often because workplace injuries make it so that people aren't able to move a lot and take care of themselves as well as they had before. And then we also see a lot of mental health needs arise around gender dynamics. So a lot of the communities that are resettled in the US have a very strong system of beliefs that expect men to work and men to be able to pay for their families. And if it's the man who's been injured at work, everything shifts. Children go out to work, female spouses go out to work, things start to get very different. And so just being able to navigate some of that tends to bring up additional mental health needs that weren't even thought of when they were initially resettled. The other thing that I really think is important to think about when we're looking at resettlement and mental health is there's a really unique set of challenges for the people who are resettled. And so I list some of them here. So there's this idea of time-limited services. So the Refugee Act of 1980 guarantees that there are services that are provided. Those services, while in the act, are very comprehensive, have never been funded in the way that they are talked about in the act, even at the times of best funding, which is not our current situation. So these services right now, any newly resettled refugee gets a maximum of 90 days services. That really is focused on getting them into a house, getting children into school, making sure they have their vaccinations. And that's really about all that can be done in that time frame. There are a few specialized programs that will work with someone who maybe has high medical needs or has clearly identified mental health needs, but those tend to, again, not really work until for more than about a year, and those provide case manager roles. There are programs that exist that people can access, but again, they aren't necessarily this comprehensive wraparound service. I think it's also really important to remember that refugees arrive indebted to the agencies that have brought them to the US. So they are meant to be interest-free loans, but they sign a document saying that they will pay back the loan to have been brought here. So they're already starting on a financial back foot. Then, of course, the one that people talk about a lot is that language and cultural learning curve in terms of everything's new, everything's different. A lot of refugees who come don't already speak English. Some do, but many of them don't. And so they're just all of those pieces, all of these things that are new. And then there are these questions about things like single mothers, families separated, the delay in processes to bring families back together. So families have a lot of questions about how do we make it work. There are a lot of single mother households that I speak to who will say that when they came over, they were told that their husbands would be coming over too. They would just come separately. And now they've been here 2 years. Their husbands are still in process to come. And their children are asking questions. Why isn't he here? Does he not want to be here? And it's very difficult to try and explain how much of this is a bureaucratic process, that you can't just bring people back together. That the refugee process is very specific and very, very long and drawn out. And then there's this idea of unmet expectations. And I have a whole slide about this. One of the things that comes up most often when I'm working with refugee communities as well as individuals is that refugees are experiencing resettlement in many ways as a disappointment. So the myth of the United States and what it can offer someone is pretty much global. The ideas and the concepts that we as a country have put out in our media and in the way that we choose to portray the country makes it so that a lot of things are expected, but they are not able to be met. So families will often talk about how high of a cost of living it is to be in the US, that this impedes their ability to support their own family in the way they would expect to, and it stops them from being able to send money home, or they find they aren't able to stop sending money home because the expectation of their family in other countries is that they would help. And so they find themselves living in very severe poverty here in the US because they're trying to fulfill the duties of their families back in other countries. There are also issues like a lack of community supports, just not being able to find the connections that they're looking for, whether it be organizations or social interactions. There just isn't enough of those connections. There just aren't enough of those connections, excuse me. And that connects really specifically to this next point in terms of collectivist versus individualist societies. When you're coming from collectivist countries have a much more consistent sense of belonging and connection for the people who live there. And so for a lot of Americans, this is really hard to conceptualize if you haven't lived within a collectivist society. But there is a sense of not ever truly being isolated. When individuals are resettled in the US, there is a lot of discussion around being lonely. And this is particularly important to refugee mental health because if you come from a collectivist culture, you won't have had to learn how to recognize loneliness or have had to build up skills to address those feelings of isolation and loneliness. And this puts people at much higher risk of mental health issues, of suicidal ideation, of substance abuse, all kinds of attempts to respond to what that feeling is without really even necessarily having the language to start talking about it. There are also some really interesting dynamics in terms of things like public transportation. So for individuals who've been resettled in Iowa, Iowa has horrendous public transportation across the state. Many people that I work with will talk about how they never had trouble anywhere they lived. Even when they were in camps, they had options for public transportation. They had options for how to get from where they were to where they needed to go. And now in Iowa, they can't get there, or they have to figure out how to pay someone to get them there. Or maybe they're taking the buses, like in Polk County, there is a bus system, but sometimes they're coming from a part of the city that doesn't directly connect to another part. So they might be on public transportation for 2.5 or 3 hours, changing buses, trying to get to where they need to be. So this is a really high level stress, and it tends to create a situation where, like for example, single mothers aren't actually able to attend their appointments because they need to be home to take their kids to school. They need to be home to pick their kids up from school. And the amount of time it takes to get on a bus, get to where they're going, have the appointment, get back on the buses, get back home, sometimes doesn't work. And that's something that organizations often don't think about. Weather is a consistent issue in this part of the country, and I think is worth thinking about. There's a group that I work with of individuals who have been diagnosed with seasonal affective disorder, who don't even know that that is something that is necessary because they've lived their whole lives until now in tropical or subtropical temperatures. And so just being able to start thinking about what is it like to not have the number of days of sunshine that you're used to, and what does it mean? You know, I've just recently had a gentleman say to me that he finds it confusing that he has a home and he's safe and they're doing fine, and he still feels so down and depressed and anxious in the winter. you know, and trying to help him understand that that's okay, that even though when he had fewer things and things weren't as safe, he had sunshine, and that can impact the way that people feel and the way that people navigate the world that they're in. And then there are just these other components that people are carrying. So there are a lot of beliefs around, you know, housing doesn't have to be a certain way, but when people come to the US, they expect it to be really nice. Again, this is part of those myths that go out there into the world from US movies and things. And a lot of the housing that refugees are resettled into is in pretty poor condition. A lot of this has to do with the fact that usually on resettlement, they don't have social security numbers, and so they're not able to be placed in particular kinds of housing because there are landlords who won't take someone without a social security number. And also because the resettlement agencies are looking for low-cost housing. There are major concerns for refugees around employment issues and a lack of a living wage. This is something that I'm often asked questions about, and there's a lot of frustration around this, not being able to get jobs that they're qualified for, not being able to understand why the jobs that they do work are exhausting but don't pay enough to be able to pay their bills. And education falls in the same realm. So we have some communities who are very well educated, but for a lot of various reasons, they aren't able to transfer all of that education information to the US. We have other populations who are not well educated, and this really limits what they can access. So there are all these pieces that apply to the experience of coming in to the US and really are related to this feeling of disappointment or not having been given what they thought they would be given when they came here. And it really severely affects mental health. I just really quickly want to check in about a couple of communities that are here in the US. So these are really specific examples. So we have a lot of Bhutanese refugees who are coming out of Nepal. This specific community has a much higher risk of suicide than other refugee communities, and they have consistently, so in countries of resettlement, in Bhutan originally, and in their in the camps as well. So this is something historically that's part of their experience. And they have a really interesting dynamic that not all of the other dynamics have, or not all of the other communities have. So they tend to have an elderly, more traditional section of the community, not well educated, were likely involved in the original fleeing out of Nepal, and are sort of trying to adjust now at this point in time. And then you have this kind of middle-aged group that was born and raised in Nepal and are actually very well educated, but because they were refugees in Nepal, a lot of their education wasn't documented, so they aren't able to get that transferred here. And then they've got their children who were either born here or came very young and who are very Americanized in many, many ways. And in this community, there's a lot of trying to manage all three levels, having grandparents who can't communicate with their grandchildren, having one or two people in that middle age range trying to keep everything together, but also being the only ones who can drive, the only ones who can work, the only ones who can continue their education. So there's a lot of distress happening through the generations. We have a lot of refugees as well from Syria, Iraq, Iran, and Afghanistan. There are some really interesting dynamics here. They're often well educated, but they're unable to find the kind of financial or employment stability that they had before arriving. Syrians in Iowa have been targeted by very specific legislation that doesn't allow them access to certain funds that are otherwise guaranteed to refugee communities in Iowa, and that's been very problematic, particularly since we've seen a surprisingly high number of separations in families after resettlement. And there are a lot of different things that are happening there, but it's very complicated for these communities to be able to find a way to stabilize. And then in your refugees from Myanmar, you have some different than expected behaviors. So a lot of times when I work with other mental health practitioners, they'll talk about how the individuals that they're working with from Myanmar are non-compliant. They won't come to therapy sessions. However, my experience has been that refugees from Myanmar are very much open to medication and like 1 or 2 visits, and that comes from how things have worked for them overseas. But they're very much confused about why they would come and see someone every week for an hour, or every other week for an hour. And so being able to really have conversations with them and talk to them about what that means, and also finding out if that's even what they want, is really, really important. Refugees from Myanmar have multiple generations that have been in camps. And there's also a really extensive history of ethnic conflicts. And so in the US, we tend to clump any refugee from Myanmar into the same group. But within the community, there are a lot of distinctions and a lot of conflicts that can arise that aren't always addressed. Some really basic but important things to think about. So stigma is something people always talk about. I always argue that stigma around mental health exists everywhere. I don't know that I think that focusing on this as a main reason people aren't getting mental health care is very helpful in refugee communities, because I think that there are actually a surprising number of people who are interested in it, but there are pieces that play into how to support refugees who are wanting mental health support or needing mental health support, but aren't really sure how to think about it. So there are individual beliefs and fears that come up, and a lot of that can be addressed through having a conversation and building a relationship with them. And one of the things that I think is really important is having people in health and public health and in mental health being present for communities, being faces of those disciplines, and being able to help build trusting relationships with them. There are also ideas about what the community expects around mental health. And so each refugee community has their own concept of what it is to need mental health support, and then how do you frame that? So for a lot of the communities that I work with, I don't go in and talk to them about mental health, but I do go in and talk to them about stress. So stress almost completely across the board, not quite, but mostly will work as a conversation topic. Things like housing, day-to-day living, finances, that's a great way to walk into a conversation around mental health. And so there are lots of ways to build those relationships and to reframe it so that you're still providing people that support, but you aren't putting them in a position where they think that you are going to stigmatize them in front of the community. And then there's this idea of, if I have mental health issues, I need to save face, or it will lead to isolation. And so being able to help people understand things like their rights. HIPAA rights are something that a lot of people that I work with really ask a lot of questions about and are very interested in. And this idea that I can't tell anything and my interpreters can't tell anything, and that it all stays there in the room. That's something that brings a lot of comfort to refugees that I work with. I also think that understanding treatment is really important, both in terms of refugee communities and in terms of us as practitioners. So I think one thing we need to keep in mind is that there are many historical and current examples of the medical field, people in the medical field, perpetrating torture in the name of, it might be something like addressing mental illness, but it also might be something like just being in a clinical setting where torture is occurring. And it's something that is pretty icky to think about, but it's a really consistent tool that is used in conflict zones and around issues of like human trafficking. And so I think that being able to recognize that while in the US we have a lot of conversation about doctors being safe or experts or important to being able to keep you healthy, that is not always the case somewhere else. And I think in the US we have plenty of examples where that also has not always been the case. And so just being able to be aware of that is very important. And then there's a lot of concern about the US government finding out. So I work with a lot of individuals who have Medicaid, and sometimes they ask me not to use their insurance. because they're worried that it will be tracked. If I'm getting mental health care, does that mean that I could lose my green card? Does that mean I could lose refugee status? Will the government be addressing that? We talked really briefly about just those educational differences, trying to work with people who have a high level of education who are refugees. The conversation looks very different than someone who has a much lower level of education. And I think being able to suss that out and figure out how you're approaching things is really important. I have often heard practitioners say that because someone's level of education is very low, that they won't be able to help them, they can't get them to understand. That has not been my experience, but it does mean more labor on my side in trying to present the information in a way that makes sense to where that individual is. And so I think it just takes a little bit of extra work and thought. And once you start doing it, it becomes easier to do. And then I think there are two really important things that we often don't think about in the US when we're talking about addressing refugee mental health needs. So there are times when being part of an ethnic-based community organization is the best option for treatment for a refugee. And there are times when having an American-born practitioner is the best for someone. And it's really about trying to figure out what it is that they need. So a lot of the feedback that I get from refugees that I work with is that I feel safer to them than someone in their community because they know that I'm not going to be where they are. I'm not going to be talking to community members. I'm not going to be interacting as much with community members. They aren't expecting or worried about me sharing information. They feel like there's more of a divide, and that makes it safer, and that increases privacy. They also often will talk about particular systems or cultural things that they don't understand. And so I can be used as a cultural broker in that way. So sometimes people don't want to come to me for mental health needs, but want to meet like once a month because they have all these questions that have come up. And so we'll just check in and they'll say, okay, well, this happened and I don't understand why, or that happened. And they said it was this, but it didn't make sense. So, just having a conversation and having that different perspective is sometimes really helpful for refugees in the US. And then having access to ethnic-based community organizations also brings some really important strengths. So the idea of having someone who understands, not having to explain what you mean or what certain sounds you make mean, right? And that familiarity of knowing what the other person is talking about, what it is they're thinking, how they can connect your ideas with what it is that you need, how they can work with your family. And it builds that sense of community. So if you're working with someone from your community within an organization, when you see them at events, you'll be able to check in with them. You'll have a better relationship formed. And so both bring strengths. And a lot of referring people and trying to get them mental health support is about trying to actually suss out what is it that they're particularly looking for. A lot of times people are more willing to talk to me about really difficult things like torture or trafficking or sexual assault. But when it comes to what their family needs and how they want to try and address something like domestic violence in the household, many times they would rather talk to somebody in an ethnic-based community organization who has a better idea and will make different assumptions about what the next steps could be. So just some really important things to think about. I always say refugees can be jerks too. So a lot of times something that happens is we assume that what's happening around us, we assume that what's happening with refugees that we're working with is that they are refugees first and foremost, and that's kind of how we interact with them. But the way people communicate can be very, very different. And so sometimes the way someone's communicating can be identified as like aggressive or unengaged. And sometimes it's just how they interact, right? And so sometimes I'll hear people say that someone was way too loud or too aggressive and they were being a jerk. And sometimes that might be the case, but oftentimes it's because of how they learn to communicate or how they've been able to get their needs met. There are also these ideas of coping skills and survival skills, and a really specific example that we have of that in Iowa is the Tigrinya community. There are a lot of single moms from the Tigrinya community that live here in Iowa, And this community is often described as being very difficult to work with, as being very non-compliant. They miss appointments, they don't engage, they complain. And on one level, that's accurate. Those are things that are happening. But spending time with the Tigrinya moms actually highlights what's happening. So this is a group that often runs into the issues of being able to get public transportation that allows them to be there for their kids when they go to school and come back. They also have spent many, many years displaced and have found that by complaining and making sure that people hear what they're unhappy about is how they've gotten their needs met. So it's actually very effective. But people here in Iowa often find it kind of irritating. And so Tigrinya moms are often painted as being jerks. And again, some of them might be, but in general, it's about surviving. Gendered power dynamics can be complicated. There are definitely a lot of practitioners, if they're female working with men, can sometimes find some really interesting dynamics there, or where you might have a male patient or client who only wants to work with a male practitioner. There are also, I mean, racism, prejudice, historical ethnic conflicts, these are things that happen worldwide. So we definitely have had incidents where someone won't work with a particular case manager because of their perceived race. There are conflicts in terms of assumptions between Africans and African Americans. And so there can be some really interesting complications with trying to just get the services that they're allowed. Basic misunderstandings, which we have all the time. So again, just being willing to ask questions and pause. And then something like really poor interpretation or not quite the right language. So there are lots of different variations of languages that are around. And so being able to check in and try to get the best version that you can is important. It also is really important to have interpreters who can do some cultural brokering. So it's not just about the words, but it's about what the meaning is, which is not always clear. So how do you become more confident and capable when you're working with refugees? I think this concept of cultural humility is really, really important. Just being able to be self-reflective and to check in. I also think being able to think about refugees as more than only a refugee. So what I run into a lot with practitioners is this idea that you're treating refugee mental health, which means you're treating that past historical trauma, and you're thinking of them as a refugee. If we think of them as these multidimensional beings, like cultural humility asks us to, we find that many of the needs that refugees are bringing to the table are standard day-to-day living struggles that they're asking us to help them to respond to. And that if we can respond to those, that's really important. I recently worked with I have a new client who recently told me that they had gone to a different clinic to ask for a particular kind of help. They had been sent to a therapist, and they sat down with the therapist who said, okay, you know, let's do an assessment. He was giving information about what it was he needed. And the therapist said, wait, don't you want to talk about your past trauma? And he said, no, I want to talk about this. We're going to lose our house. I have 4 children, you know, these specifics. And the therapist said, well, but we need to talk about your trauma if you're going to feel better. And so he said that was really frustrating for him. Because for him right now at the moment, what's most traumatic is the safety of his family and the fact that he's not able to maintain that, if that makes sense. I also really think this idea of trusting your clients and patients and expecting that the community knows more than professionals ever will. While we are generally situated as the experts in the way that US culture works, we are not the experts, I would argue. And that the idea is that by being able to step back and ask what they need and ask what they want, we can actually provide a lot more help and support, and it takes a lot less time and work. I also, in that critical self-reflection piece, I really encourage practitioners to think about, like, what is it that you're worried about and what is it that you're expecting, and to think about that beforehand. A lot of people don't like using interpreters. Why does that make people uncomfortable? If you're somebody who speaks more than one language, you know that interpretation from one language to another doesn't always look like what you expect it to. But for a lot of Americans, you know, there are a lot of Americans who don't speak more than one language. And so sometimes just the discomfort in having two people have a conversation that you're not able to understand can be really distressing. So think about that. Why does that bother you? Why does that distress you? What do you think is happening? And how can you address that? And then thinking again about what you're expecting, how they should act or behave or feel. And does that make sense? Is it okay to actually have them fall outside of that criteria that you've set in your mind? The answer is yes, but how do you get there? How do you get to where you're okay with that? And then just these last three at the bottom. So always use an official interpreter. It helps so much. Not using family members, not using friends, using an interpreter who can help with some of that cultural brokering, and takes away some of that emotional connection is really important. Reflect back what you think you're hearing. I have a friend who's a doctor who says that that's a really therapist-y thing to say, and I would agree with that. But the idea is if you reflect back what you think you're hearing, they will tell you if you're right or not. It is so easy. For me, I'm wrong 100 times a day, easily. I reflect back something that I thought I heard. No, they'll say, and then they'll help clarify. Really important to do that.
Exactly.
And then just expect to be wrong.
I could possibly because I have a low grade. Okay.
The really specific strategies that have been shown. So there's no actual evidence of like this program or that program across the board, but there are some things that have been shown to work. So really giving your clients and patients the degree of freedom to shape their own definitions, what they think is traumatic, what they think mental health is, what it is that they need, and what they're asking you to do. Really, really important for them to have that power. Focusing on the challenges and experiences in the resettlement environment. So looking at what's happening here and now, and if you reach a point where you're interacting with people about their history, that's great. They're allowed to make that decision, but it isn't about refocusing them always to the past. Work with people where they are right now and on what they're dealing with here. One of the other things that's been shown really consistently is that children and adolescents receiving direct therapeutic services has an incredible benefit to them. And so really, when you're looking at referrals, really prioritizing getting access for children and adolescents to some kind of therapeutic support is really, really important. And this is more than just going to see a school counselor now and then, but really getting them some therapeutic engagement. Formal and informal groups, always very helpful. Just listening. So I really consistently hear people say that it matters less to them that I wasn't able to resolve something, and it mattered a whole lot that I just sat and listened to them, and that we had a conversation about how difficult that is. And I think that that should be common sense because these are human beings, but I think because we often define refugees as refugees first and only, we forget. Community building, social connections, just making sure that people aren't alone and kind of trying to address that shift from a collectivist to an individualistic society. And then really explaining what's happening. So if you're working with someone in any kind of a health situation, really giving them as much information as you can instead of assuming that they already know or that they'll get why you gave them that medicine or why you want them to come back. Really talking them through what you're thinking and why. So that's all that I have for today. This is my contact information if you need it. And I put a couple of books here that I think are really, really good, that I think would be useful if you haven't read them. I spoke for longer than I had hoped to, but I want to make sure and see if people have questions or any kind of input that you'd like to give before we finish.